Does anyone see the biliary abnormality, first of all, that's in this case?
Biliary tree anomaly.
Yeah.
There is a
Trifurcation.
trifurcation. Yeah.
Yeah, exactly. So this is the right anterior duct, which is usually the more vertical one because it's draining segment 8, which is a bigger segment of the liver. And then this is the posterior duct, which is more horizontal. And normally they should both come together and then join the left duct. And here they have two separate insertions here. So that would be important if you were doing either IR procedures or a hepatectomy. They would have to, make sure they knew that there was two separate things here. And then the other thing is there's an abrupt truncation of the duct here. So this patient had just undergone a cholecystectomy and now has an elevated bilirubin of 12.
Oh my gosh.
And basically they clipped across the common bile duct. The other interesting thing about this case is they did an EOVIS scan. And this is the 20-minute EOVIS scan. And we do not see any excretion into the biliary tree.
Really backed up.
What'd you say?
Must be really backed up.
Yeah, exactly. So that's one of my points is that if the bilirubin is elevated, you don't want to give EOVIS, and you want to see EOVIS being excreted. Usually we use a cutoff of about 10 to 12. Above that, the liver dysfunction is so much that the EOVIS might not even be excreted. And I have a little paper diagram to show this. So the way that these hepatocellular, the hepatobiliary contrast agents get into the hepatocyte and then get into the bile duct is by these OATP transporters. And those OATP transporters also transport bilirubin into the hepatocyte. So if your bilirubin is too high, then it's going to selectively get transported into the hepatocyte and kind of like clog up your liver. So your hepatocellular agent won't go into the hepatocyte and then it won't end up getting excreted into the biliary tree. So if it's too high, in this case, they wanted to know more about the biliary anatomy, which we were able to show with the MRCP. But the fact that the EOVIS wasn't excreted, we kind of knew that was going to happen because the bilirubin was so elevated.
Do you use EOVIS in most of your liver imaging?
No. And actually, this is another reason why so for characterization of lesions, generally, for example, the arterial phase and other phases, you'll have not as much enhancement with EOVIS. We prefer to use non-hepatobiliary agents, but we will use it for differentiating FNH from adenoma and bile leaks, mostly. With biliary obstruction, it's usually this case where it's so obstructed that you're not even going to get the excretion of EOVIS. But
our practice is basically the same.
Yeah, some people use EOVIS for detection of more metastases.
Yes.
Which I think is good. If you have like baseline scans, then you can use EOVIS and then you can see if new lesions are washing out, like for melanoma patients or.
That could be very good. I saw a patient from whose image at our place had been previously imaged at Stanford, and they had done that. They used EOVIS, and it was an endocrine neoplasm metastasis of the liver, and it was way easier to see on their MRI, in part due to the use of EOVIS to detect the mets.
Yeah, so, and we do, one of our colleagues does MR guided ablations here, usually of like tiny colorectal liver mets, but he does it under general anesthesia and gives EOVIS, so he has like a lot of delayed excretion. And by the time the patient comes to him and he gives general anesthesia and like has a beautiful breath hold, he usually finds a lot more lesions than we saw in our traditional scan. So then our surgeons were asking us like, hey, can't we do this for everybody? And we're like, no, we can't give everybody general anesthesia and, do like a multi-hour long scan, but it definitely does pick up more lesions.
I was doing a presentation on EOVIS for another case, and I didn't realize, but the reason EOVIS is taken up is because there's a molecule attached. So it's Magnavist, and then there's a molecule that looks just like bilirubin, which is what makes EOVIS different from Magnavist. But that's why it's taken up by the same transporter as the one for bilirubin, is because it's the same molecule, or it's a slightly different variation of it. So
cool. I actually forgot, I had a paper I wanted to show you guys about liposarcomas. So I don't know if this is going to be recorded or mess up the recording, but can you guys see this paper?
Mm-hmm.
Okay. So just a couple of really quick points about liposarcomas. So one thing is differentiating them from lipomas. So lipomas are pretty common, but they're much more common in the extremities. So if you see them in the retroperitoneum, and if it's greater than 10 centimeters, and if it has any thickened septations or more solid components, then we get more concerned it's a liposarcoma. So this is just like what an ultrasound of a lipoma would look like, and they're pretty common in the extremities. And then this actually goes to Steve's point about what compartment things are in. So this is like my example of retroperitoneal pushing the kidney and pushing the anterior pararenal fascia forward. This one is a rare liposarcoma that was actually in the peritoneal cavity, but you can see it's pushing that anterior pararenal fascia backwards, and it's kind of more centered with the bowel loops and the mesenteric vessels. And then this is that notch sign that shows that, for example, it's arising from the kidney for like an angiomyolipoma.
So if you see A, it's probably a broader differential because of the location. You're gonna
exactly, yeah. It could be a sarcoma, could be gist. Actually, I would prefer, like, for example, a gist tumor here if it's centered in the near the small bowel. And then this is a well-differentiated liposarcoma, and you can see, like, differently than the lipoma, it's actually got more thickened septations. So that would be more concerning for a liposarc. And then this actually is a nice example of a combination of a well-differentiated and dedifferentiated liposarcoma. So it's got the fatty components with the thickened septations, but then the more solid components to it. And there's one more point. So there's a variant called a myxoid liposarcoma. These are more common in the extremities, but they tend to be like myxoid looking, so they're very T2 bright, but they have a lot of enhancement to them. And you can even see these in the retroperitoneum. And the important part is actually they respond more to radiotherapy. So if we see something that looks like this, we'll raise that possibility. And then one more point actually is that PET can help you. Generally, liposarcomas are usually not very PET avid, but when they get dedifferentiated, they'll be more PET avid. So if you want to target your biopsy or look for more dedifferentiation, you can get a PET. Okay.
Awesome.